All right, so this little thing here is called the adrenal cortex. All right, pituitary is in the brain. Adrenal cortex is where? Where does the adrenal cortex live in terms of anatomy in the body? Okay, you're heading in that direction. I heard a kidney there, Sarah. On top of the kidneys. Yes, the adrenal cortex sits atop the kidneys, thus making a network from the brain to the kidney. And, that particular endocrine pathway is very important to know because we have these two issues of the adrenal cortex that you will see time and time again. You will see them in multiple classes. I don't know why we love adrenal cortex so much, but when things go wrong with the adrenal cortex, it's a big deal. So very important. Tell me what adrenal cortex is really known for. What's its importance? Marissa? Yes, I love it that you think of fight or flight first. Absolutely. If you go into fight or flight for whatever reason, or even if you're just stressed, it doesn't have to be like, again, my common example is a bear shows up right there outside the classroom and we all have to figure out what we're going to do. It can be you're sick because you're a nursing student and you can't get enough sleep. And so you have this virus that you've been trying to fight for a week. Okay. That could send your body into a certain type of stress response, right? And because of that, it's a great side note, because that happens, when people are sick, they kind of go into a low-grade fight or flight. We take their blood sugars often in the hospital, patients, right? Because the very fact that they're sick will sometimes drive the blood sugar up, okay? And that's what adrenal cortex does. It drives the blood sugar up immediately so that we can have the fuel and energy we need to run away from the bear, okay? But that said, it causes hyperglycemia if you don't have a bear to run away from, all right? All right, so in the cortex, whenever we're talking about like the brain or the adrenal cortex, the cortex is the part that's on the outer layer. That's what cortex kind of means. It's like the outer layer. And then the medulla usually implies something more deep in the inner layer. Okay, so the cortex, called the zona glomerulosa, you don't have to know that for the exam. All right, no cortex and you're good to go. Right, puts out aldosterone, that is the hormone of maturation. All right, cortisol, the hormone of stress, and androgens, also no, let me take this back. Androgens are the hormones of maturation. Aldosterone is specifically connected to water. I want you to think of like water exchange in the body and the kidneys. Okay, aldosterone is going to be important for that. All right, the medulla is where the catecholamines are made, and the catecholamines are known as epinephrine and norepinephrine. That's where they are made. So we get the cortisol in the cortex, right? They have the same root word, right? The cortisol is made in the cortex, whereas the epinephrine and the norepinephrine, the catecholamines, are in the medulla. So when you think of the adrenal cortex, I want you to think of salt, sugar, and sex. All right, as you go from the outer layer of the cortex to the inner layer, salt, aldosterone, we mentioned the fluid exchange, salt and fluid go together, okay? Water and salt go together. So salt, aldo, sugar, cortisol, sex. And we say sugar for cortisol because, again, when that bear shows up to that door and we go into fight or flight, it's glucose that's going to be going to all the important peripheral muscles so that we can run from it, okay? So sugar, cortisol, sex, androgens. These are the hormones of maturation, all right, in both female and male patients. All right, so let's move. We have another graphic here. It's just a little bit more simple than the one you see in porths. All right, and adrenal cortex on the outside. There's a capsule over the adrenal cortex, right? But there's the adrenal cortex, and then the medulla is inside. Okay. And that's a little bit of a cross diagram of the actual adrenal gland. Okay, medulla internal, capsule, and there is our cortex. All right. So when a person doesn't have enough adrenal hormones, or the hormones of salt, sugar, and sex, right? If they don't have enough of these adrenal hormones, they get a condition called Addison's syndrome or Addison's disease. I'm going to give you a little way to help you remember Addison's versus the other one, which is kind of like the opposite of Addison's, too much adrenal hormone. I'll tell you about that in a minute. But the primary treatment for Addison's disease is to add a steroid. All right. I know we're talking patho now. We'll get to the treatment in a minute, but that's how I keep up with it. With Addison's disease, you add a steroid. All right. They're missing steroids. Steroids are interchangeable with the cortex hormones. All right. Using the word, the actual long version of the word steroids is corticosteroids. Okay, so corticosteroids come from the cortex. All right, so to fix that issue, we add steroids. Okay, so that said, and that's all the endocrine problems. If there's a problem of inefficiency or insufficiency, too little, we simply add the hormone, which is one of the toughest things we'll do as nurses, right? Because we have to add hormones. Hormones are these ethereal things that come into the bloodstream when you need them. So we have to schedule things in a very conscientious way because we're almost trying to mimic the body's way of providing the right amount of hormone when it's needed. Okay, so that said, the primary issue with adrenal insufficiency or Addison's disease is too little cortisol, all right, or plus or minus too little aldosterone. And aldosterone is which one? The sex, the sugar, or the salt? The salt, right? So too little aldosterone, they're going to have hyponatremia, which is, what is that? Hyponatremia, too little salt in the bloodstream. Okay, so too little hyponatri, saltemia in the blood. All right, so too little salt. So too little aldosterone, the salt hormone, too little in the blood. All right, too little salt might give you hypotension, right? Because the water and salt, they flow from areas of high concentration to low concentration. So if you don't have enough salt, you don't have enough water, you're going to be hypotensive, which also means too little water volume in the blood. Okay. You might be, the relationship between salt and potassium. Have you heard about that yet? The relationship between salt and potassium? Okay, good. So too little salt, you're probably going to have too high potassium. Okay. So do those make sense? Now this hyperpigmentation piece is just it's a little symptom that we use when we're observing and assessing the patient, like with our assessment skills. We might see that these patients typically are hyperpigmented. It's not like, they actually look tanned all the time. Yeah. So when a person has adrenal crisis, they will, usually it's because of illness, shock. When you have too little cortisol, what happens, well, what do you think happens when they get excited? Too little cortisol is being fired off. So what happens if, or when the fight or flight system is aggravated, what do you think they do? What do you think their response is to the bear approaching the door? Are they going to fight? Are they going to flight? Or are they going to faint? They're going to faint. Yes, they're going to just not be able to handle it. They don't have the cortisol on board to help them react or respond. So typically they will pass out. They will go super hyponatremic. Hypotension alone will make you experience, kind of like this dizziness, all right, or passing out. Okay, so those are some major signs of Addison's disease. A lot of times too, you can go into Addison's disease. It's similar to insulin, where if you take too much insulin but you don't eat, you can go hypoglycemic, right? Well, similarly here, if you're taking steroids, because I mentioned corticosteroids are the treatment for too little adrenal hormones. If you abruptly stop them, you have to taper steroids off, because if you abruptly stop them, you could potentially experience adrenal crisis. okay? Sometime. All right. So let's move on to the treatment. Okay, so what do? Glucose, corticoid, right, born in the cortex of the adrenal gland, all right, is what we do. We do glucocorticosteroids, replacement therapy, okay? So hydrocortisone, that's what we give, hydrocortisone. Here's a table from your Abrams book, all right, adrenal corticoid, mineralocorticoids, and the names that you will typically see fludrocortisone, hydrocortisone. And those are some of the brand names as well. All right, the patient should split the doses, AM, PM. You don't want to, with all of these endocrine drugs, you do not want to pile them on. You want to consider spacing out their administration across the day, because that's how hormones work endogenously, right? You don't get a big burst of hormones all at once. You get your hormones as you need them. Brain, pituitary, that connection there. They survey the body. The brain is pretty amazing, always surveying the body for too little or too much of something and trying to keep that balance, right? So we typically try to imitate the body's endogenous hormone cycles. So we might split that dose morning and afternoon. All right, we have to have a plan for illness or surgery where they have a stress dose, all right, a little higher dose to help support them in a stressful scenario. Okay, remember, illness will trigger the fight or flight. All right, the adverse events of chronic glucocorticoid use may be weight gain, hypertension, hyperglycemia, infection risk, and osteoporosis. All right, weight gain, does that make sense? All right, makes sense because of the hyperglycemia. Hypertension, does that make sense? So if part of Addison's disease is hypotension, as we mentioned here, if you're taking more glucocorticosteroid, then there's the possibility to go over into hypertension, okay? That's the problem with these endocrine drugs. You have to strike a balance. You don't want to go too much or too little, or you create different crises. All right, hyperglycemia, all right, makes sense, right? Because of it's right there in the name, corticoid, all right, is going to give you more glucose available, free in the blood, not getting into the cells. All right, and infection risk. Why do you think infection risk goes with more steroids? Why do you think a person taking steroids or introducing more of this glucose into the body will increase the chance of infection risk? Hint, hint, folks who are diabetics have a high risk of infection too. And what does that do? But yes, beautiful, absolutely, yes. So it takes a little bit of thinking to get there, but it's the inflammation response that's keeping the body in that inflammatory state, right? And that does not help us with after a chronic, like in the short term, it's wonderful. People love to be on steroids in the short term, but in the long term, there are all these terrible adverse events. So we really have to monitor people who are on steroids, okay? Osteoporosis is a long-term risk as well, and it has to do with the calcium connections involved in Addison's disease, right? They have all these different electrolyte imbalances that can lead to calcium being pulled from the bone, and it can lead to osteoporosis. All right, so what do we do? Mineralocorticoids. So that's not glucocorticoid, but mineralocorticoids are the fludrocortisones. All right, but the problem with them will be that any patient, right, on a steroid or on any corticoid drug, right, has the risk for hyponatremia and hyperkalemia, right? So we have to keep an eye on their orthostatics. What are orthostatics? We said sodium, and sodium will be off, so the water salt relationship will be off, thus making us hyper or hypotensive. When that salt level is off, we have the risk for becoming Hypo? Yes, hypo. So hypotensive people, people who dip into the double digits over double digits, okay? 90 something over 60 something. All right. We want to take frequent blood pressures on those people because orthostasis is the act of like kind of standing up after being leaning over a little bit and becoming dizzy or lightheaded. That's hypotensive. Orthostasis. Hypotension. So when you see orthostasis or orthostatic, think hypotension, never hypertension. Okay. And what that means for you as a nurse working with your patient is that you're going to have to do frequent blood pressure checks, see where that blood pressure is. All right. Because these steroids, because of this relationship to salt, all right, hyponatremia goes with hypotension. Okay. So we need to keep an eye on the orthostatics. We monitor the electrolytes as well when the patient's labs come in. We just do a quick check. If they're hypo anything, we try to keep their electrolytes balanced. Okay, so patient education is huge here, telling the patient to take their medications, spacing it out, not skipping a dose, not doubling the dose unless there's a reason to, and actually keeping that medical alert ID on. Why would we want a patient to have the medical alert ID given? Yeah, absolutely. Fall risk. Hypotensives have fall risks. Okay, all right. So we have to consider whenever we're dealing with drugs on the HPA axis, HPA would be hypothalamus, pituitary, adrenal. All right. All the different commands come into the hypothalamus. It then sends a message to pituitary to start creating the necessary hormone. And then we go to adrenal to get those hormones created and administered into the body. Adrenal likes to sit next to kidney because a lot of that hyponatremia stuff, you want to have the target organ near where it's going to do its most business, right? So if you got a hyponatremic patient, in order to make those adjustments, adrenal gland needs to be near the kidney so that it can quickly adjust those salt levels and water levels. All right. So an abrupt cessation after prolonged therapy will cause adrenal crisis. Okay. I wanted you guys to see the anatomy again before we move on a little bit more. That again, the hypothalamus gets the central nervous system input. Some message comes to the brain regarding too little or too much of a hormone or the demand for a different hormone, right? Then that signal goes down, that releasing hormone goes into the anterior pituitary gland, all right? Then the hormone, the tropic version, right, which is kind of like the pro-hormone or the pre-hormone, hits the target gland, becomes the hormone, and then hits the target cell. Okay, so it's quite a bit of a process. It all happens quite quickly. All right. Again, another depiction. This one, though, shows that you go from the central nervous system to the hypothalamus to the pituitary gland. All right. And then you have all of these possible target organs. Okay. So the posterior pituitary, all right, the lobe that hangs in the back, all right, is going to create oxytocin and ADH, whereas the anterior pituitary, right, will be creating growth hormone. The two sex hormones, FSH and LH, luteinizing hormone and follicle stimulating hormone, are going to go to testes and ovaries. Okay, testes will create testosterone, ovaries will create estrogen and progesterone. Okay, anterior pituitary will also go to thyroid and create our thyroid hormones, TSH. Okay, and then anterior post pituitary, as we're talking about today, will go to adrenal gland and create the glucocorticoids. All right, so getting a little bit of a pathway or making a concept around what's happening here will help you greatly and take you far, I think. All right, so steroid replacement, something to think about as you prepare your drug cards. Hydrocortisone, going to take daily, carry medical alert. Need to know why. All right, if the person's sick, has fever, vomiting, surgery, they'll take an additional dose called the stress dose. All right, per the plan that's already been set up for them. Usually it's part of their care plan, but also they should seek care. All right, watch for dizziness or low blood pressure, hypotension, orthostatics, all right, are the terms we're thinking here. Think about weight gain because of the hyperglycemia, swelling and infections due to the inflammatory response that it has been in this prolonged chronic state, thus actually working against us and creating more of a risk for infection. Fludrocortisone may be added if the hydrocortisone isn't doing the trick, all right, but we're going to have to monitor the blood pressure, sodium levels, and potassium levels, okay?